Dear friends, colleagues, that's a great pleasure to be here. Now we are reviewing some cases about the peripheral usage of the shock fast in performing cases of TAVI and other peripheral stuff. Actually, I'm presenting on behalf of my friend. He couldn't make it here, so I'm just presenting on behalf of him. The first case, 88-year-old lady with post-CABG status presenting with progressive dyspnea and orthopnea. ECG shows AF rhythm, narrow QRS complex, LVH, and hemoglobin was about 9, eGFR less than 30, normal LV size and mild systolic dysfunction over the echo, and severe degenerative mitral stenosis also was appreciated in the echo, and it showed severe symptomatic AS with mean gradient of 55. This is the assessment of periphery. When we performed the Trimencio analysis, we assessed periphery to assess how it could be performed via transfemoral access. And this is the assessment showing less than 5 millimeter in right iliac and also common femoral arteries. And also on left side that was heavily calcified. Anyone would go with the transfemoral TAVI in this case? Any of the colleagues performing TAVI? No? Going left or right? Anyone would comment? No? If we are not able to perform the transfemoral TAVI, what about the other access? Alternative accesses are performing via the transaxillary, transcarotid, and transcaval. And also, if we have no option in these three alternative accesses, we might go with the transapical or transaortic access. And there is one possible option after the 2020 when the IVL was introduced, and that's facilitated transfemoral access. Now we are today speaking about this access. Transfemoral TAVI trend over the last 5 years, we know that alternative access has diminished because now we have this facilitated transfemoral access option. And over the time, our threshold for performing alternative access actually decreased from 10% in 2016 to the less than 2% nowadays in 2025. We should be vigilant about the calcified arteries. When performing the TAVI or any large bore access procedures, we should know that if there is no calcification, 75% of the outer sheet diameter could be enough to perform the procedure. And when there is calcification, it is better to be 20% even bigger than our sheet diameter. What are our possibilities to perform the TAVI over these difficulties? We might have some iliofemoral calcification, we might have iliofemoral tortuosity, and also aortic angulation. All these difficulties might, be resolved with the POBA, IVL, atherectomy, vascular snaring, body wire, and balloon-assisted delivery. And if we have no other option or it is not resolved, we might go with the transaxillary, transcarotid, transcaval, and transapical access. What do we know about the IVL feasibility based on calcification pattern and severity? If it is 360 degree or 270, we could be able to perform the IVL assisted transfemoral TAVR. If it is diffuse, it is also an option to perform the IVL. And if it is even focal or very small in the calcification, it's also an option for us. The only obstacles might be when we have the minimum diameter of less than 3 millimeter, and we could not just pass the peripheral IVL. And in this situation, we might go for alternative access. What data shows about the performing a TAVI over the transfemoral or IVL-assisted transfemoral TAVR? Over the last 3 or 4 years, many trials actually addressed this problem, and they showed possibly all-cause death or a stroke might not be different in these situations, but even performing the transfemoral IVL-assisted TAVR, we might have difficulty in case of vascular complications. It really changes, using the alternative access, but still we have some difficulties. And it is a kind of a way to make this impossible way to be possible. And this is the summary of all observational study, which showed in case of in-hospital death and a stroke, the rates are similar, but still we have higher vascular complication. What do we know about the peripheral IVL? It is started from the size 2.5 to 8. And the compatible introducer sheath is from 6 French to 7 French, and we could perform. And one difference is the rate, the number of the total pulses, which might be in some balloons like 400 and 300 based on the sizing. This is also the image of shock fast, and also we have the sample here if you want to just work with it after my lecture. Well, this is the assessment of first case. We went through the right and decided to perform the IVL over the right side because it had some narrowing in the external iliac artery, and following the IVL, we could pass the sheath over the balloon, and finally we could perform the TAVR in this access. And this is the moment of the passing the wire, passing the valve through this right common iliac artery after the performing peripheral IVL. Otherwise, that was impossible to pass the device. And this is the final result. We performed it with the God bless valve accurate NO, and this is the final result on the right side, showing no perf, no dissection, and no major issue on the right side. The second case, 80-year-old man with medical history of diabetes mellitus, hypertension, dyslipidemia. He also presented with severe aortic stenosis, and we planned for performing a TAVI through his excess. Echo showed preserved LVEF, severe AS, and this is the peripheral assessment of the artery. As you might have appreciated, this is a very diffuse narrowing from the distal aorta to the right common iliac and left common iliac artery to the distal common femoral artery. So in this case, we also decided to go with the peripheral IVL. This is the image of distal aorta, also showing some difficulties in this part, and we thought sheath might not go further on. So this is the calcification showing over the wire. As you might have seen, we were able to pass first the dilator over the right common femoral, and then performing some IVL over distal aorta and common iliac arteries. And this is the image. This is the peripheral IVL also over the left and distal aorta. This is the image on the right side. And this is also the IVL on the distal aorta to be able to pass the sheath. And finally, we could go with the sheath and finally perform the TAVI. And this is the image after performing the TAVI. As you might have noticed, there is no difficulty or issue on the distal aorta and right iliac and femoral arteries. The third case, 82-year-old man, also presented with the same side effects and complaint of the previous patients, depicted the severe aortic stenosis, and this is the cine image of the common iliac and femoral artery, showing narrowing on the distal external iliac and even at the access site, we might have some difficulty. So we decided to go with the peripheral IVL here. This is the after performing the IVL. Its symmetric expansion of the balloon is here depicted, and this is the image after performing some shocks and pulses over the right side. And finally, we were able to pass the balloon and the stent and then the valve through this access and finally perform implanting of the valve. And this is the final result over the right side. No major dissection, no perforation. So when we are performing and working with large bore access, we have to be vigilant about some difficulties. Performing TAVI needs, we prepare our shelves for any difficulty that we might come across. And we need to be able to know the other alternative access too. This is not always the solution for any difficulties, and you have to be preferred to be able to conquer any difficulty. Thank you very much, and also you can just work with the peripheral IVR here. Any question? Anyone performing TAVI here? Colleagues? No? We perform actually a couple of cases which we need to go for alternative access, and that's when there is a nodular calcium. We believe that even performing the IVL might not solve all the issue with nodular calcium. Also, it is a kind of a cracking the calcium in coronary, but in peripheral, there might be some difficulties with the nodular calcium. But otherwise, now I think this is a very good alternative to performing transfemoral access, and I think the reason why the rate of the alternative access decreases is usage of the peripheral IVL.